we're going to get started. As I mentioned, and as you can see, instead of going into discussing Standard 6, which is a lot of looking at different clinical outcomes and different measure outcomes within the practice, an area that I know specifically for PCMH, a lot of offices haven't really discussed it or even looked at it all yet, which is fine. So instead of looking through that standard right now, I thought it was a good idea to go back and just look at a few different areas where we may have discussed them on previous webinars or in different face-to-face meetings going over some things, but just some areas where there's repeated questions and needing further clarification, or just a reminder of what is recommended or needed for those different areas. So if any other questions that I don't cover that you have, feel free to let me know and I'll make sure I address them either one-on-one or next time that we have a webinar, office managers meeting, any of those areas. So again, I'm not going to go through each factor in any specific in any of the specific standards, but just again focus on the main points and where there's been different areas of concern. So here, just kind of a simple question, a straightforward one from the beginning that is still a little unclear, I think, for some people is how the process is laid out and the different content within the recognition process. So this slide shows the blue numbered boxes, which there are 6 of, showing the 6 different standards. So 6 standards which are the basis for the program, and each containing the lettered elements within them. So there you can see 27 different elements throughout. Keeping in mind again that the must-pass elements, that there's 1 per standard, that those are the ones that are asterisked and have the most weight on them as far as points and importance within that standard. Looking at the different scoring levels, just wanting to point out again that there's 3 different levels, and looking at the highest level, that the minimum requirement for that is 85 points. So not saying that we shouldn't aim for doing everything that we can, but that there is that leeway there where if some things just aren't going to be done, if some of them are just going to be too much challenge or too much change, or something that we think that we could get away with as far as meeting everything else, there is that area where we don't have to be doing every single one of these different pieces of information. With that in mind, if we did half of everything, say half of every single point level, you'll see that that would put you down at level 1. So we do want to reach those higher levels, and also keeping in mind that most payers recognize and give reimbursement at levels 2 and 3. Some payers with level 2 and 3 getting the same reimbursement for some things, and some payers having level 3 get a little bit higher reimbursement compared to level 2. When we do submit to NCQA and when we do receive our scores and recognition level back, you can see in the left-hand side in the box I have included that we do get scores for each element and standard, and the number of must-pass elements that we achieved, and then our total score. So they do show you which areas you scored less, and because of that, we're able to, if we did come in at level 1 or 2, we're able to do what they call an add-on, and within the time frame that we have, we are able to then submit for some of those areas that maybe we didn't submit anything for, or weren't going to do at the time, and over months or a year we begin to implement. We can add on to get to those higher levels. So for that, they do give score breakdown based on those different areas. This slide I don't believe was in what I had emailed this morning for the materials, but I did include this and I'm not sure if it's something that I've included before. I know I've gone over it with some of the physicians, but just a little breakdown of how an element is looked at and how it's read. And if you have the full guidelines, this is the way that that's laid out. But starting at the top where it says PCMH1, patient-centered access, that will always be included, and that is indicating the standard that this element falls into. So the standard is always a number, so you can see here that this is standard 1. Beneath that, it gives a little statement of purpose for this standard, and then it goes into the black box where you see element A. So the element is always a letter. And in that line there, you can see that it will indicate if this is a must-pass element, and it will also tell you the points that are available for that specific element. And above that, the specific points for the whole standard. So standard 1 has 3 different elements within it. So we're only looking in this example at element A. There's also element B and C. So those 3 elements together provide for 10 total points. Underneath the element letter is a little brief description just for this specific element, and then the various factors. So here that this one has 6 factors, and indicating that some elements have a critical factor within it, as number 1 is for this element. Other little things to point out with how this is laid out under the scoring, you can see here for 100%, the practice would have to meet 5 to 6 factors, and including factor 1. So to get the highest level points, you need to make sure that the critical factors are met. For any must-pass element, which again this is, the requirement is that the practice earns a score of 50% or higher. So here for 50%, the practice would need to meet 2 factors, again including that critical factor, which is factor 1. So that's kind of the hierarchy: 6 standards, 27 elements, a lot of factors. But how each element is broken down is with that standard number at the top, followed by the letter, and then the varying factors that fall within it. So you'll see things labeled 1A, and that just is meaning standard 1, element A, and then any numbers that are after it are referring to the specific factors that fall within that. Just some random miscellaneous items. Again, the first 2, what I just talked about, that there's 1 must-pass element per standard. So since there's 6 standards, there are 6 must-pass elements. The must-pass elements, again, must have a score of 50% or greater, and that's to get any recognition level. So if you completed every single factor for all of the standards, but in standard 1, your must-pass element didn't have a score of 50%, you wouldn't even be eligible to get level 1 recognition. Those must-pass elements have to have the 50% or greater. Something that's come up a lot is how a practice can define a personal clinician. So as you see there, a practice may define a personal clinician as a combination of a physician with a nurse practitioner with a PA who share a panel of patients. So when we submit to NCQA, we give, this is all again site-specific based on geographic location. So when we submit, we would be submitting we would include the information for the physicians at that practice. And if, say for instance, there's a PA at that practice who has their own panel of patients who does not share a panel with one of the physicians, they specifically see all of their own patients, they would be listed as an individual clinician at that practice. Whereas if the PA only shares patients with one of the providers, sees that provider's patients, then only the physician themselves would be listed when we submit for who are the clinicians in that specific site. Keeping in mind again that all documented processes, which a lot of these elements require, They must be implemented for at least 3 months before anything could even be looked at being submitted to NCQA. So all of these documented processes and policies that we're putting together have an implementation or revision date on them, and these need to be in place for at least 3 months before anything is looked at. So we can't create all of these policies this month and have them all in place in July and be thinking that we can submit anything before the end of October. But even the end of October would not be feasible because there's a lot of tweaking and different changes that would need to be going on. So that's why the full transformation takes several months. And that's something that we're well aware of. It's not, again, something that we think is going to happen overnight, and we'll be ready to do this quickly. As I mentioned, practices that receive level 1 or level 2 recognition may apply for an add-on survey. A recognition period is for 3 years. That's when we would look to have to renew for the recognition. But anytime within that 3-year period, if you're recognized at level 1 or 2, again, you could apply for an add-on survey and submit more documentation or things that were adjusted that we didn't get full score on the first time, or things, again, that we didn't have implemented or submit for at all at the first submission, to, again, move up to level 2 or 3. NCQA reserves the right to audit a practice that has applied for or has a current recognition. So again, they're including while the applicant survey is under review. So at any time in that process, after we submit, we are subject to an audit, and you can see that NCQA does audit 5% of practices. The last thing at the bottom there is just the link to the previous recorded webinars. So those that discuss standards 1 through 5 are all in that YouTube link, and accessible anytime. All of the handouts should be in Medin, and if not, something that I could easily email you if you don't have them for specific webinars. Okay, going into this slide, what I did is went through each standard and kind of picked out those areas that I know have again, either caused concern or I've frequently been asked to further explain, or if certain things would meet this, or if certain documentation would meet it. So just wanted to go through some of this clarification. So you can see there that this is looking at standard 1, which is all about patient-centered access. So in element A, quite a few of these factors, there's 6 total factors for this, but since this is an area that for many practice is an adjustment, figuring out what is required and what would be sufficient has been a big question. Again, this is a must-pass element, so to meet the 50% threshold, that would be meeting factor 1, which is having same-day appointments and at least one other factor. So for factor 1, which is the same-day appointments, again, this is the practice reserving time for same-day appointments for both routine and urgent care. So this is a dedicated time slot within the physician's schedule. And you can see there the second bullet, adding ad hoc or unscheduled appointments to a full day of scheduled appointments does not meet the requirement. So this is an area that requires a documented process or policy. And if, stating in there that your policy is if a patient has calls and needs to be seen, and your business hours are until 5 o'clock and you just fill them in and the doctor says they'll see them then, that's not what they're looking for. They want to see that this is embedded into the schedule, that there are slots for when a patient would call that day. There is no mandatory requirement of how many of those time slots need to be in there. So it's not saying that there needs to be a certain amount each day, but that these same-day appointments are available. Factor 2, the routine and urgent appointments outside of regular business hours. So appointments scheduled outside of the typical daytime business schedule. So I mentioned before with a lot of the offices when I was talking about this, we say that a normal business day for most places is 8 to 5. So NCQA is looking for, outside of that typical 8 to 5 Monday through Friday time, that the office has appointments that patients can schedule if they just cannot meet within that 8 to 5 time because of work or other schedules. You can see different examples there. Open for appointments certain days at 7 a.m. If they have Saturdays that they're open in the morning. And you can see what it does not include. So it cannot include daytime appointments. If an office normally closes for lunch, it can't be putting them in there. Appointments when they would normally be closed on a holiday and just having them come in on that day. So one of the offices that I've been working with have changed their schedule so that now on Mondays the physician is seeing patients until 6 o'clock. And I had asked NCQA just to get clarification if that was enough, if having one day a week that they were open later like that until 6 o'clock was enough, or if it needed to be more. I believe they were looking at doing 2 Mondays a month, and that is sufficient. If that meets patient needs and patients aren't asking for more than that, if those time slots are being filled and there's not need for more, then that is sufficient. Because as you can see with the examples there, open for certain days at 7 a.m., open 2 Saturdays per month. So it's not saying that every day patients need to be seen until 8 o'clock at night. It's just that when the need is there that it's offered. Okay, and that last bullet there, if the practice does not offer these hours, if they just can't because of staff requirements or whatever the reason may be, within their documented process, within their policy for how they do outside of regular business hours, there needs to be some type of process for arranging after-hours access with other practices or other clinicians. Factor 3, alternative clinical encounters. We've been looking at these as scheduled telephone visits, scheduled home visits seem to be the two that are most feasible, and that if physicians are currently doing any of these, those are the two that they've been doing. But again, ad hoc telephone or email exchanges do not meet the requirement, and the two big things being that they have to be scheduled and they have to have clinical basis to them. If the doctor would see that a patient already has a scheduled in-office visit, and for whatever reason, whatever the meaning for the appointment is, if the doctor identifies that this patient can have this visit by alternative means, so whether it is something that can be done over the phone, then coordinating that with the patient would be okay. So a lot of questions around how it is scheduled, but if it's something that they see that can be done, again, scheduling over the phone, and they find out that that is okay with the patient, they could do so that way. Factor 6 is identifying opportunities to improve access. So that is looking at you analyzing, looking at information from the previous 5 factors to identify any area that can improve access. Some of the examples that you see down there is just increasing or shifting around same-day ability. Shifting, if, say, again, the office that I talked about, having after hours on a Monday until 6 o'clock. If they look at a week of measuring that, and after a few times, or from patient feedback, it seems though if they did that on a Wednesday night, that would be better for whatever reason. So different ways of looking at that. On the next slide, you'll see a little example of this, and this template, how this is laid out, is available to put in your information. But again, they're only looking for you to select one opportunity to improve access and at least one action that you took to create greater access. So you can see here that this example, looked at no-show rates, and their opportunity there in column B is monitoring the number of patients who do not show up for their scheduled appointment. And then in column E there, the action that they took, which for them was a reminder process. And then you can see there the performance at remeasurement and how they followed through with that action. Okay, looking at some key areas of Standard 2. In element A, factor 3, they're looking for a process to orient new patients. So element A is all about continuity, and there is a policy brochure template that really satisfies what they're looking for. The main points, as mentioned there, is to provide information about the medical home and the different responsibilities that both the practice and the patient has. And again, there is a flyer that basically has all of that information already embedded into it that you could tailor if you want to change any things around. But that is basically a brochure, again, just looking for an area to provide this information as you get new patients. Factor 4 in this standard is having a written care plan for transitioning from pediatric care to adult care. And there's slightly different requirements for pediatric practices, family practices, and internal medicine practices. And I have there that new templates were added to that test account where all the documents are. Actually, they weren't put in there yet, but I will add them today. And they are different for each of those areas. So one for pediatrics and how they will transition their pediatric patients into adult care, whether that be within that same office if the practice sees adult patients as well, or if it's to a new office, and what they will provide. And same for family practices and internal medicine practices receiving patients from pediatric sites. For element B in Standard 2, this is all about medical home responsibilities. So specifically looking at Factor 3, sounds a little vague and not really knowing what is to be documented for this, but the factor reads that the practice functions most effectively as a medical home if patients provide a complete medical history and information about care obtained outside of the practice. So what NCQA is looking for is that you are informing patients that the practice will function this way and function most effectively if the patients provide you with that information. So I have mentioned there that there is an FAQ document for patients, and again, it satisfies a lot of the factors within this element. It explains a medical home. It tells what the practice is responsible as far as coordinating care for the patient. It talks about providing equal access regardless of source of payment, gives uninsured patients information about how to obtain insurance. So a bunch of different factors that fall within this element that FAQ document satisfies. And this could be something that is part of your process of orienting new patients. So when you have a new patient and you give them these new materials or handouts, providing that FAQ document in there and informing the patients about it is what they're looking for there. Looking into element C, 2C is all about looking at cultural and linguistical services. So I just wanted to point out that there are two different factors around providing different materials or services. There's 4 factors within this element, and factor 3, which I have on here, that is looking at interpretation services or bilingual staff provided regardless of need. So factor 4 is where there's an option for NA, which is, for most of our practices, having to provide printed material or education material in a language other than English. But keeping in mind that factor 4 is, for the most part, NA for our offices, but factor 3, they are looking for some type of service or bilingual staff regardless of what that breakdown of the population language is. For element D, which is the must-pass element, this again is looking at the whole practice team, and you can see there that meeting 5 to 7 factors, including factor 3, which is the critical factor, would give you that 50% minimum score. So factor 3 is the patient care team meetings or the huddles. So this is a review of the daily schedules. There is a template for how you can some areas to look at, questions to ask, and then document just as you would meeting minutes. But again, this is specifically looking at information regarding who is on the schedule for that day and any follow-ups that we would need to have before the patient came in, or anything as far as having them complete before they see the physician when they get into the office. So this is looking at specifically patients on the schedule. Factors 5, 6, and 7 are discussing training and assigning of members for those 3 various areas: care coordination, self-management, and population management. There are a few documents with policy templates for how you can assign these different members and different training that you can use. So there is a video training document that has, for care coordination, a link to watch a video, a check mark box to say that it is completed, and because they do ask for how individuals on the team are trained in these certain areas. So we do have a document that has different links to videos to watch and where you could sign and check that those have been watched. I have included on there a few different example roles for some of these areas that offices hadn't had before. There's been a lot of question of exactly what they entail or what their responsibilities or roles or that staff description would look like. So there I just added a few that would fall into those different categories for care coordination, self-management, and population management. For factor 9, care team staff involvement in the practice's performance evaluation and quality improvement activities. So this could be around clinical measures and clinical outcomes, or it could be around office functions, or like you see there, patient experience, operational things in the office. So it could be including both clinical quality measures and operations within the office, or it could focus on one or the other. But it's just showing involvement from the whole care team staff, not just the physician looking at those areas. It's everyone's involvement in those different areas. Factor 10, a lot of resistance towards this factor, involving patients in quality improvement activities or on a patient or a practice's advisory council. So again, those quality improvement activities, this is not looking at patient feedback from surveys, that falls into a different element. But there you see, at a minimum, the practices process specifies how patients and families are selected, what their role would be within that team, and how often this team meets. So this could be a once-a-year, twice-a-year thing. And I do have an example, and it's more, I believe, than NCQA needs for this, but it at least would give you a basis of how some other places have implemented this, and it's something that I will provide as a handout. Looking at Standard 3, just wanted to talk about a couple things in Element A. So Standard 3 is all about population health management. And specifically in Element A, just a few different areas, keeping in mind for the whole element to enter either none or declined or unknown, wherever that's an option. To receive 100% for this element, 10 to 14 factors are needed. And I'm pretty positive that most offices, if not all, are doing already 8 to 9 of these. So implementing the documentation of a couple more of these will take us from 75% of the points to the full 100%. So looking at Factor 8, documenting occupation, so this could be either in the history or the patient's employment status, where you can choose from different things as not employed, unknown, retired. So filling this in either of those areas. Factor 10, legal guardian. Again, this is looked at in the contact section in the HIPAA screen. And for Factor 12, advanced directives, and this is something that is going to be re-added into the DMHM. A couple different areas of documenting it, but for us, after request of a couple physicians, it's going to be re-added to that area. Standard 4, which is the standard all about care management and care support. Looking at Element A, I will be providing, I know there's already a template for the policy, but I will be providing a policy that will be able to be used without change to all of the offices based on conditions that have been chosen at a committee level. So you can see there for the various factors. Factor 1, them looking that there is a behavioral health condition that identifies patients and manages care. So looking at these conditions, again, that were chosen, a practice can most certainly choose a different condition for any of these factors, and I'll work with anyone that does that to adjust the policy as needed. If there's something specific that is important to them or however they want to look at that, you can definitely do so, and these are just those that are going to be included in a standard policy. Looking at Element B and C, which Element B is care planning and self-care support, and Element C, medication management. So for those two elements, you would want to be looking at these different conditions that were chosen in Element A and focus specifically on incorporating the factors that fall within Element B and C into those patient records that fall into those categories above. So keeping that in mind, that's not to say that every person that falls into one of these categories in that chart above are eventually going to be reported on, because you could see that quite a few patients can fall into some of those categories. But it will be a random selection of these patients that are identified, and then it will be a look back to see if the factors within Element B and C were in fact documented into those patient records. So it is a random way that the patients are chosen that we report on, but by having these conditions set and knowing which conditions we want to focus on for care management for these specific conditions and criteria, at least we have a basis of what patients we would be having that look back on. And these are those patients that we, with different quality programs, they're looking at as well, and that we see as important conditions. Element E is looking at the support of self-care and shared decision-making. So just for a few of the factors there, I have some references in different areas where different tools can be found. Patient education is something that we're obviously already doing and have in place, but looking at different self-management tools and shared decision-making aids. So those are just some ideas of what examples of those look like and where you can get some of that information. Standard 5 looks at care coordination and care transition. So just briefly there, element A, which is test tracking and following up. So looking at that we have a system of tracking and flagging and following up on any lab or imaging results that are overdue, how our system flags abnormal results, all that. I have created a template for that. If not by the next, definitely by the next office managers meeting, I'll be able to provide that to you. But that's not one that we had a policy for that a few people have asked about. So just want to let you know that that will be given to you soon. Element B, which is the must-pass, is referral tracking. So for factor 2, I just wanted to point out, this is looking at having agreements with specialists, and the wording in the guidelines is a little misleading, but it is looking for either formal or informal agreements. And as you can see there, an informal agreement can be that expectations are indicated within the referral request form, and that those expectations need to include the timeliness of the response and the content of the response from the specialist. So NCQA is only looking for one example of this, but they are things that need to be embedded in there. The same for element C as with element A. So element C is looking at coordinating care transition. So getting reports or information from hospitals of unplanned visits, how we share information with hospitals and emergency departments, different things along those transitions. Again, is another area where there isn't a policy in place or a template to be used, but I have worked with a couple offices and created that based on how it seems like most of the offices get this information and how MEDIN is utilized for that. So that's another one that will be distributed to you soon. The last standard, standard 6, looks at performance measurement and quality improvement. So element C specifically in this standard looks at the measure of patient and family experience. Factor 1 being that the practice conducts a survey to evaluate the patient experience, and it's been asked, and many offices obviously have some type of survey that they've used, and you can use any patient survey, but it must incorporate 3 of these 4 areas, being access, communication, coordination, and whole person care and self-management support. So if you already have a survey that you use and you just want to use that, it may take some tweaking to make sure that it addresses 3 of those areas. But there is not a specific, for this factor, a specific survey that you have to use. Factor 4 looks at that the practice obtains feedback from the patients through qualitative means. So it cannot be in that survey that you use for Factor 1 that you have items that they can just write in any information, or that there is just a comment section at the bottom where they can write anything. It's looking for something separate than that. It could be a suggestion box within the office that is just left out in the office, and that is looked at for their feedback. And it could be, as you see there, anything through individual discussions with the patients, focus groups, any type of information that you get some qualitative feedback. Element E looks at demonstrating continuous quality improvement. So this is the only area that you're asked to demonstrate that you improved your performance. So with most areas, they ask for what your process is, if you maybe have goals for a certain area, but there's nothing saying that you need to really meet that goal. It's just wanting to see that you have something in place that you work for, but here they're asking to demonstrate improved performance. And they ask for it in 4 different measures. 2 looking at clinical quality measures, 1 utilization of care, and 1 patient experience measure. But this template of this example is similar to the one that I showed for standard 1. And here you can see how this was done and how they showed their improvement. So I just wanted to show here that there is an area where they ask for improved performance for certain measures, and that there is a document template that is available to show that in a pretty straightforward and easy Excel document. That is all that I have, but if anyone has any questions, and if anyone does not have the guidelines, the full booklet of all of the standards and guidelines, I'd be happy to email that to you. The same with if I haven't had to come into the office and meet with you, or if you would like to come to the central office to speak with me, I'm happy to do that anytime, and just let me know in any specific area or anything in general that you want to discuss. Happy to do so. And thank you everyone for getting on today, and hope everyone has a good weekend.